Well, my watch says that it's 10:01 Pacific time, 1 p.m. here in Toronto, Ontario, where I am. So I'm going to get this started, and thank you all for joining us this morning. My name is Anthony Quinn. I'm the Chief Community Officer at CARP, working out of the national office in Toronto, working from home this morning. My duty is to welcome you and be the host for this first ever virtual webinar hosted by your CARP British Columbia chapters. And we're excited to put this on to you and bring you this event in a time where we're not able to meet together in person. So thank you everyone on the line for joining us this morning. I want to introduce you to our panelists this morning. We have representatives from 4 CARP chapters in British Columbia. From the CARP White Rock South Surrey chapter, we have Ramona Captain, and Ramona is the president of the CARP chapter in White Rock in South Surrey, and she's also a member of the National Board of Directors of CARP. Welcome, Ramona, and identify yourself with a wave. Some of the names are off there. We have Fred Harwood. Fred is the president of the Richmond Delta chapter. Fred, welcome. Can you identify yourself there with a wave? Fred, are you able to hear me? There. Fred, are you able to hear me? No.
Yes, I've been waving.
Okay, well, you're frozen then. I can't see you moving, Fred.
I can hear you.
We have Karen Terrell.
Yeah?
Karen is the president
you can't hear me?
of the CARP North Fraser chapter. And along with Karen, we have Tim Hicks, who is the past chair of the chapter. Welcome to Karen and Tim. And in the top right-hand corner of my screen, but I'm not sure where she is on yours, we have Karen Bailey-Remenko, and Karen is the president of the CARP Kootenays chapter. Welcome to all of our panelists. Now it's my pleasure to introduce our keynote speaker. We're pleased today to have with us the Seniors Advocate of British Columbia, Ms. Isobel Mackenzie. And just a little bit for you all about the Office of the Seniors Advocate. They monitor and analyze senior services and issues in British Columbia and make recommendations to government and service providers to address systemic issues. The office also provides information and referrals for individuals who are navigating senior services and tracks their concerns, which helps inform their future work. Now our keynote speaker herself, she is Isobel Mackenzie, and she has over 20 years experience working with seniors in home care, licensed care, community services, and volunteer services. Isobel led BC's largest not-for-profit agency, serving over 6,000 seniors annually. In this work, she led the implementation of a new model of dementia care that has become a national best practice, and led the first safety accreditation for home care workers. Among many other accomplishments, Isobel has also been widely recognized for her work and was named BC CEO of the Year for not-for-profit sector and nominated as a provincial healthcare hero. So, welcome very much, Isobel. Thank you for joining us this morning, and I will pass the floor over to you.
Thank you very much, Anthony. Good morning to everyone. And I really appreciate the opportunity to engage through this new Zoom medium. One of the things that I highly value is getting out and about and talking with seniors throughout the province. And so, Karen, I'm very happy that you're joining from the Kootenay, and I hope a number of participants on the call are from all parts of British Columbia and hearing directly from people. Because, Anthony, you talked about, yes, we use the information and reports that come into our office as ways of identifying systemic issues. But I find the greatest value is when I'm able to get out, see people in the communities they live in, and hear directly of the issues and challenges that they face as seniors. And certainly in the year ahead, that engagement is going to look different from this office. To put it in perspective, I spend normally about 40% of my time out of the office going about to places like the Kootenays, up to Fort St. John or Terrace, and finding out. So we're working to try and find ways to keep that engagement going in this new normal of the year ahead. And as in many things, CARP is leading the way in coming together through this Zoom call. So I really do appreciate the leadership that you're showing. Now, I am also learning new technical skills, so I'm going to hit a button here called Share Screen, which I think is going to put my PowerPoint up, and I'm going to spend hopefully only about 15 minutes maybe. I'm quite anxious to get to the questions. I see there's 42 of them. I've read some of them. Some of them I can't answer, but some of them I can. So let me get started with my share screen here. Okay. All right. Now, what I need to do is slideshow and from beginning. Okay. I'm hoping people will tell me that they can see the slideshow on the screen with a thumbs up, correct? Okay.
Yep.
All right. Okay. So I'm just going to start with a little bit of quick stats to give everybody a bit of perspective of what the situation currently is in British Columbia. So we have 5.1 million people who live in BC, and these numbers are live as of yesterday, I believe. As you know, they change a little bit, but we currently have diagnosed or tested positive 2,530 cases of COVID-19 in British Columbia, which represents 0.05% of our population. We have most unfortunately seen 161 deaths due to COVID-19. That represents 0.003% of our population. We have tested 135,190 British Columbians for COVID-19. 98% of the tests are negative. And I just want to highlight that the testing criteria in British Columbia has varied a bit, but it has focused on folks who are showing some symptoms. So they have a cough or a fever, they go to get a test. It's 98% of the time it's negative. We've also tested people who aren't showing symptoms, but have been exposed to the virus. So healthcare workers who are in a care home that has had an outbreak, for example, or close contacts of somebody who's tested positive. We will also test them if they're what we call symptomatic, meaning they're showing signs of illness, but we also test them if they aren't showing signs of illness, because we know that the test can be effective in the 48 to 24 hours before the onset of symptoms. And so using that criteria, we're finding a very high proportion of the tests are still negative. So that's a good thing. That tells us that we are certainly testing widely, and we are turning up the cases that we need to turn up. Now, as you know, seniors are, there's different age definitions. My statute, my legislation defines it as age 65, but I've had to deal with how the data are reported around COVID, and so I've had to use slightly different age groupings. So I've had to cut off, I've used 60 as the cutoff because it's in 10-year increments starting at 60. So in British Columbia, we have 1.3 million people 60 years of age and over, and that's 26% of the population. The actual seniors population, 65 and over, is about 20%. Within that population of 60 plus, we have 896 cases of COVID, or 35% of the cases. So it's important to understand that 35% of the cases, but 26% of the population. That represents 0.07% of the 60 plus population. The deaths, however, tell a different story. So 155 of the 161 deaths have been in people age 60 and over. That's 96% of the deaths, or 0.01% of the 60 plus population. When we look at the much older population, we have 238,000 people who are 80 years of age or older, which is 5% of the population. We have 334 cases of COVID in the 80 plus population, which is 13% of the population. So 13% of cases. So 5% of the population are representing 13% of the cases. So that also tells us something. And that represents 0.14% of the 80 plus population. So you can see that it's had the biggest impact in terms of cases on the 80 plus population. And that to a large extent reflects the outbreaks we've seen in long-term care. 112 of the deaths, or 75% of, or 70%, pardon me, of the deaths have been in the 80 plus population, or 0.05% of the 80 plus population. So, and I've got some epidemiological slides afterwards to show as well, but you can clearly see that the 80 plus population has felt a disproportionate impact from this virus. There are 430 cases out of our 2,530 that have been in our long-term care homes. 264 of these are residents and 166 are staff. There have been 89% of deaths, or 89 deaths, or 55% in long-term care. Now you'll notice there's little asterisk after that. That number will increase as we adjust our data. Right now, the death is recorded if the person dies in the long-term care home. If they're transferred to hospital and die in hospital, right now, the data is showing the place of death as the hospital, which would translate to the community. So we know there aren't a lot of transfers from long-term care to hospital with COVID, but there are some. And some of those people are successful in their treatment in the hospital and return to the long-term care home. Some do die in hospital. And so there'll be a little bit of adjustment, and you can expect that the percentage of deaths of people who live in long-term care will be a little bit higher once the dust settles on all of this data. 31 long-term care homes have had an outbreak. This represents 9% of all long-term care homes in British Columbia. And I think we really need to let that sink in for a moment. 91% of our long-term care homes in BC have had no outbreaks. We've had none on Vancouver Island. There were none in the north. And there were only a couple in the interior that were isolated to one staff person, and the outbreak was contained. Really, the outbreaks that we've seen have been in the Lower Mainland. I also, this number has teased out assisted living, which is different from long-term care. It's regulated differently, it's controlled, it's funded differently, everything. So I think for my purposes, I've tended to look at, okay, what is it in long-term care, which is where we have good data. 8% of the cases have occurred in publicly operated care homes. 78% have occurred in contracted care homes, and contracted but publicly funded, and 15% have occurred in fully private homes. And those are the number of cases. When you look at the outbreaks, again, you see proportionally a much higher proportion. It's, I think, 4 times greater proportion in contracted versus owned and operated. I think there's only been a couple of owned and operated outbreaks, although one of them in Berkeley was a fairly significant outbreak in terms of the numbers. And I think it's also we need to remember this, and this is particularly, I think, important as we look at how we're going to address the visit policy ongoing during this pandemic, is that each year in our long-term care homes, about 8,000 people pass away. So every month we see about 650 plus residents pass away in long-term care homes throughout British Columbia. And during this period of time, we've seen 89 deaths due to COVID. So overwhelmingly, the people in our care homes who are passing away from illness conditions, very much not COVID, although they could be an influenza or a respiratory illness, but it's not COVID. One of the things that I have a fair degree of confidence in is that we are testing for COVID, that we are not seeing cases of COVID go undiagnosed, or COVID deaths due to a COVID go unrecognized in our long-term care homes in BC. In the population at large, that might be possible. In the very, very early stages, is it possible that in February or March, early part of March, that somebody passed away from COVID in a care home or transferred to hospital and we didn't pick it up? That is possible, but if it happened, the numbers would be very, 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 very small if it happened at all. So living and income. So currently 93% of people 65 and over in British Columbia live independently, 4% in what we call congregate housing. So that's where you're going to capture your assisted living, your seniors independent living, that's the 4%, and 3% live in our long-term care homes. When we look at the population of 85 plus, that's the average age of a person in long-term care in British Columbia. At that point of 85 and plus, 72% still live independently, 11% now live in congregate housing at that point, and 17% live in long-term care. When we look at income, the median income, so median means 50% are above this and 50% are below it. It's a little bit more meaningful than average, which can be skewed by a bunch of people at the high end. And, you know, if you had, I always demonstrate that if you had 200 people and 100 of them earned 50,000 and 100 of them earned 100,000, you'd have an average income of 75,000, even though nobody made 75,000. So median is a bit more of a meaningful indicator. In 2019, 264,000 BC seniors, about a third of our seniors, received the Guaranteed Income Supplement, the GIS. This is a very good proxy for the level of poverty amongst seniors, because it's not just the individual income, it's tied to your spouse's income as well. So if you are getting GIS, either living alone or living with your spouse, you do have some income challenges. Your total income had to be below 25,000, and I think the average for people on GIS hovers somewhere around $20,000. And in BC in 2018, 56,000 seniors received the BC Senior Supplement. These are the lowest income seniors in the province. Their income is below $19,000 a year. So 56,000 is not an insignificant number of people. It's not a high percentage, but it's not an insignificant number of people, and they certainly have some significant income challenges. So I've got a couple of slides that were presented in the modeling update. So these data are a bit old. They're as of April 30th. The trajectory or the pattern of these data have not really changed as we've moved through the month of April. And it just reinforces a couple of phenomenon that your risk factors are your age, whether you're male, and whether you have at least one chronic condition. So you can see how the likelihood of being admitted to hospital, the likelihood of being admitted to an intensive care unit, and the likelihood of death increases if you have one of these risk factors. What is also very interesting is the outcomes by age and gender. And so what you see is that when we look at the case count, there is a significant bulge, if you will, in that sort of 50 to 59, 30, basically the 30 to 59 age group. That reflects the care workers who have contracted. They tend to be younger. They also tend to be female. So you see a higher proportion of females than males, pretty much right across the board. And then you see this higher rate of the virus in the younger age groups. When you look at who is admitted to the ICU, so actually let's go down to, first of all, it starts with hospitalization. So then if we look at, okay, who gets admitted to hospital, then we see things shifting to the older age group and shifting to male. So you're starting to see that the difference between men and women, if you look at 50 to 59 in terms of who gets admitted to the hospital, you know, it's more than twice as many males as females. Gap, you know, narrows a little, 60 to 69, then starts to widen up a bit as you get into the older age group. And certainly at 90 plus, you can see, again, more than twice as many men who contracted COVID versus women at the age of 90 plus are admitted to hospital. And you see that pattern continue in the admitted to hospital. The other thing now, I've got pictures on my screen here that are blocking the very last bar of my graph. I can't see it. I don't know if you guys can. But if you look at who died, here's what is very interesting. Let's start at age 80 to 89. 20% of the women died, 30% of the men died. So that is also telling us that 80% of people over the age of 80 who contracted COVID-19 did not die. And nearly 63% of the men who contracted COVID over the age of 90 did not die. When you go to age 90, this is where the disproportionate impact on men is very, very evident when you look at this death rate. So I can't see the final bar. Someone correct me if I'm wrong. I'm going by memory. I think it shows 50% of men thank you, 50% of men over the age of 90 who contracted COVID died versus 20% of women. So more than double in men. That is a phenomenon that has been experienced around the world. It's not the Canadian phenomenon, because the Canadian phenomenon is being influenced by the mass numbers coming out of Ontario and Quebec, and we're going to have to sort out why that looks different. The BC experience mirrors more what the international experience is, that men succumb to this more than women. So what has been the impact of COVID-19 on seniors? So first of all, prevention. Health and wellness for seniors. What does that look like? Well, that's about getting to your fitness centers, your recreation centers, your senior centers, your libraries, and your socialization. All of those things severely restricted and eliminated for a 2 to 3 month period of time. So what's going to be the impact of that? That I think we don't know the full story there. And we know that some of these things are not going to be as robust as they were in the coming year ahead. In terms of care, our allied health, which is things like, well, we put foot care there, but more probably appropriate, physiotherapists, massage therapy, podiatry, those kinds of allied health. Most of those services were put on hold and heavily restricted for the 2 to 3 months. Primary care physicians, physicians continued to serve their patients. A lot more did it remotely. And I know there's some questions about that. That may be a good thing. That may have caused some challenges. We're not sure. Acute care, surgeries, we know a very significant, I think it's 30,000 plus surgeries were canceled, and then the additional surgeries that would have been scheduled weren't scheduled. And we know that we had significant reductions on visits to the emergency department. What's the ultimate impact of those? We don't know yet. That's going to be a lag indicator that we are going to be measuring in the months and possibly years ahead. Our home and community care programs, our adult day programs, our home care programs, our respite beds. Home and community care continued. Home support visits continued throughout the province. Home nursing care continued. Adult day program was shut down, and respite beds in care homes were basically shut down. And there definitely will be an impact, particularly on the family caregivers, from no longer being able to have those 2 or 3 days a week of respite that they got when their loved one went to an adult day program, or the week or 2 or 3 weeks of respite they got when their loved one went to a respite bed in a care home. And we'll be starting, I think, to see the results of that hardship during the COVID. Congregate care, assisted living, independent living, those continued. New admissions, obviously, new residents moving in, that was heavily restricted. Some suites, some operators chose to keep them empty. When people did move in, they had to be isolated for 14 days. And certainly there have been a number of isolating and protective measures in our assisted living and independent living sectors that have restricted visitors to the people living there and have restricted the people living there. It's looked different in different settings. That's one of the challenges that I have, is that we the different approaches that were taken around interpretation. And I think as we look to the fall, and I think we need to come to a better understanding of consistency throughout the province. And that segues into long-term care, or nursing homes, where we did see admissions from the community for a period of time were suspended. Admissions from the hospital continued. There would never be an admission from a hospital to a care home experiencing an outbreak. So given the number of outbreaks we had in the Lower Mainland, there were a number of pressures on long-term care as as beds sat empty without somebody being able to be admitted. And people who were admitted usually were isolated for 14 days to ensure that they didn't have symptoms. And then, of course, the visitor restriction policy and what impact has that had. Financial challenges. Now, for seniors, income really was not altered. So pensions continued to come in. The impact on the market not really felt immediately. That is a lag indicator yet to come. Seniors who have employment would have felt some impact from that employment potentially being altered. Just going to get my door closed here. Excuse me for a minute. Excuse me, could you close my door? So we see that the ones who had jobs, who had income disruption from the loss of the jobs, would have been able to access CERB grants and those kinds of things. But I think the financial challenge, first of all, the challenge on the markets, it has yet to be felt. And I think we need to recognize that there's another shoe to drop, which is how much is my dividend income going to be down? How much is my nest egg going to be down that I'm drawing from? And we don't know where things are going to sit in the market a year from now. But costs increased, and that's, I think, the bigger pressure. Food in particular, and a number of seniors, certainly in calls to my office, have experienced an increase in part because they can't go around and shop the bargains the way they used to do, and go in one shop and get apples because they're 98 cents a pound this week, and go to another store to get the fresh oranges because they're on sale at that store. That all sort of went out the window with the COVID restrictions, with the requirement to get food delivered. You'd get it from one store, and so you paid whatever the price was in that one store for whatever you needed. And sometimes you had to pay a delivery charge if you weren't able to get one of the community programs that was delivering food. Medication, a number of British Columbians experienced an additional dispensing fee. That, for the most part, has dissipated. That was in British Columbia, that was an industry decision, not a government decision, to limit dispenses to 30 days versus 90 days. There was concern about shortages, pharmaceutical shortages. Those concerns, in the end, didn't materialize to a significant degree. And so most pharmacies are now dispensing on 90 days and have been for over a month. And our advice to people is, if your pharmacy will only give you 30 days, phone around to another pharmacy and you'll likely find one that will give you a 90-day dispensing. Transportation. So as it became more challenging to use public transportation, to use buses, because of the exposure that seniors were vulnerable to, many had to start paying for personal transportation, taxis, things like that they wouldn't normally have to pay. And telecommunications. One of the things that became apparent was some seniors, particularly poorer seniors, didn't have internet because they couldn't afford it. They'd go to their library or their senior center to use the internet every day or every other day. Couldn't do that now. Had to get internet, had to get a device that they could Zoom on, or those kinds of things. And so those costs went up for a number of seniors as well. So what kind of financial assistance was out there? The province gave a $300 automatic payment for 3 months, so each month, so $900 for the year, to those receiving the senior supplement. So those are our most economically challenged seniors, our poorest seniors. So the $900 that they will get is not insignificant. It's the equivalent of a 10% increase to their income. The provincial government also gave $50 million to the United Way for programs that support seniors. So this is not money into a senior's pocket, but it is providing services that they can now get through Better at Home and not pay for. So an example would be the grocery deliveries, the medication deliveries that you might have to pay the store for or the pharmacy for. Better at Home will deliver volunteers actually were delivering them for free. The house cleaning, for example, those kinds of things. Now the $50 million is, I think, about a 2-year funding envelope, but it was to fund the expansion of 211 to all areas of the province. So, for example, out in the Kootenays now and up in the north, you can now just call 211 and be directly connected and get the help you need. And then they gave $500,000 to the Family Caregivers Association of BC to increase the supports on their phone line and their virtual supports to family caregivers in the time of the kinds of restrictions we're seeing now with adult day programs and respite. On the federal front, there was a one-time doubling of the GST HST credit. So again, that will target low and modest income seniors. An additional one-time tax-free payment of OAS of $300 and GIS of $200, so $500. Everybody will get it automatically. Everybody who's eligible for OAS will get the full $300, even if you normally have all of your OAS clawed back, you will still get the $300. They have temporarily extended the GIS and allowance payments if the 2019 income has not been assessed. So they're very aware of a number of things are tied to what you report as your income. And they're aware that the processing of income tax will be slower this year, certainly for those who have challenges and need the help of accountants and tax clinics to do it. The RIF, the minimum withdrawal limit has been reduced by 25%. That will be helpful for those who are experiencing this bouncing around in the financial markets, so that if they can keep their money in there, they can potentially recover some or all of their losses from this year. The federal government gave $9 million to the United Way of Canada. I don't know that we will see much that will have a big impact in British Columbia. I think that will be felt in other provinces to a greater extent. They also gave $20 million to expand the New Horizons for Seniors programs. We will wait and see what the impact of that will be in BC. It will depend on what programs are funded. And they have worked to take what are our traditional tax clinics and make them virtual, so that seniors with low and modest incomes can get their taxes done. So the future, and then I'm going to wrap it up and turn to the questions. There's a lot of lag indicators that aren't available yet. So we don't really know the totality of the impact of COVID-19 on seniors. We know the virus itself is virulent and vicious and prolific amongst the seniors population. We know what it looks like in congregate settings. The impact of what I'm going to call the fallout, so all the containment measures, all the financial impact, we don't know yet. And we will be measuring that in the months and years ahead. It has put a spotlight on seniors issues that I think and hope are going to receive much needed attention. So low-income seniors. I think it was underappreciated what it means to be a low-income senior and how many low-income seniors there are until you realized that they don't have internet because they can't afford it. And how are we going to address that? Because don't assume everybody has internet. And don't assume that if they don't have it, it's because they don't want it. Many don't have it because they can't afford it. Long-term care. I think that it has certainly highlighted the challenges that are there. In a perfect world, if we could run our long-term care homes the way I think we want them to be run, the way many thought they were being run, it doesn't mean we would not have seen COVID in a care home. It doesn't mean we would not have seen a death in a care home. But it does mean that we would have had greater comfort to know that everything that could be done was done, and that we are allowing a dignified way of living for our seniors in the last 2 to 2.5 years of their life. In the months ahead, we need to look at the data and the evidence to understand the systemic issues that need to be addressed in the long-term care system and how to improve it. And we really need to be guided by that. And there'll be a lot of chit chat and a lot of messaging and a lot of other things. At the end of the day, the numbers are really going to tell us the story, and we really need to understand what are the patterns. Why did these care homes experience outbreaks? Why did these care homes not? Within the outbreaks, why did these care homes limit the outbreak to 1 or 2 people, and these care homes sought gallop away from them? We need to understand what the similarities and the differences are and find those patterns. Some patterns will absolutely exist, some won't, and it will help guide us for the future. And it's going to be really important as we move forward not to lose the current public support, which translates into political commitment to improve seniors' care in Canada. It really is there right now. The heartening thing has been the outpouring of empathy and sincere caring for our seniors that you have seen as the totality of what's been happening in care homes has exposed itself. Again, we listen to the numbers. This virus kills seniors, and it kills seniors in care homes to a disproportionately greater effect than other people. And what we found was not indifference to that. What we found was, this isn't right. We have to do what we can to fix it. And I think now is the time to mobilize that. And where there is public support, there will be political commitment. So that's the job of all of us to maintain that and retain that. So I think that's all I'm going to present, and I will turn it over for questions. And I'm not sure, Anthony, are you moderating the questions?
I am. Thank you very much.
Okay.
So I'm going to try and get everyone back on my screen. Excuse me. All right. Well, thank you very much for that very insightful look into the state of play with COVID in British Columbia. I know that what we're seeing in other provinces, including Ontario and Quebec, has been a much more dire situation. So thank you for sharing the details on what's happening in British Columbia with everyone on the line today. We have with us a number of our presidents of CARP chapters across the province, and I wanted to allow each of them to ask the advocate a question and perhaps have a little discussion amongst the chapter presidents and the seniors advocate on that topic. We'll go through 4 or 5 questions, and then we'll open up the floor to questions from those who are assembled quietly right now in our audience. So the first person I want to give the floor to is Karen Terrell. Karen is the current president of the CARP North Fraser chapter and has quite a background and interest in the care of seniors, particularly with dementia. So Karen, can you take the floor, please, now?
Hi, Isabel. Thank you so much for supporting CARP today. We really do appreciate this. So because of COVID-19, it really has shone a spotlight on long-term care. And, but we do know that systemic deficiencies have been existing for years. And so one issue that has come up quite a bit with our CARP members is the concern around staff and resident ratio within long-term care. And I think you can appreciate that. So it is clear from our members, from hearing from families and the residents, that this is an issue that needs to improve, and especially around giving care to individuals affected by dementia. So my question to you is, do you feel we need legislation to make this happen? And does BC need to have a commission or inquiry into the quality of care being given in long-term care so that we can better support our seniors?
So I'm going to try and make my answers short so we can get to as many questions as possible. So number one, I do believe we need resident staff ratios in regulation, the way we do for childcare. I have come 180 degrees on that, Karen. When I was working in the field, I didn't support that. I was on the, we know best, people are different, let us, but sitting where I sit now, when I see the differences that exist, when I see how things are rationalized, no, I think we need to regulate ratio. We've got a little bit with 3.36 hours per resident per day. That's not quite the same as a staffing ratio. I think a staffing ratio is stronger. And it's also not embedded in regulation. And I think it needs to be, because then it can weave back to licensing and how it's inspected, right? It's too broad right now. Sufficient staffing, what does that mean, right? That's what we have in the regulations right now. So I think, yes, we need to do that. Do we need an inquiry or a commission? I'm not so sure. I think that we need, we've got a lot of information. We, I think, need to look at where we've aligned the incentives. We need to look at the data. I think there's issues around staffing, what is related to the staffing level, what is related to staff training, what is related to staff turnover, what is related to differential wage rates. My office did a report, A Billion Reasons to Care, looked at the contracted sector, which is the biggest sector, how they spend their money. Very different, very distinct pattern between profits and not-for-profits, but it's a pattern. So you would find a not-for-profit that did the same as a for-profit and vice versa. You look for what is a pattern as a systemic issue. I think we need more conformity, more standardization, and that goes against what we've basically been talking about, right? Which is, as the operator, I know my residents, I know this, I wanted, let me just give me the money and I'll figure out the best way. That isn't working. It works sometimes. It isn't working. So, I don't know whether that's a commission of inquiry or not. I think, Karen, the perception is because right now the numbers support that British Columbia has done fairly well relative to the rest of Canada. Not to say we couldn't have done better than we did, but relative to the rest of Canada, we've done better.
Wonderful. Thank you so much.
And may I just add to that question, Isobel, if we need regulation changes and perhaps legislative changes to those ratios, what would be the way forward with that? Is it up to our individual members to call their MLAs, to call the health minister, to call the housing ministers and demand it? What should they be doing to see these changes happen?
I think individuals are important, and so are unified lobby groups, which shouldn't be important, but they are, is my observation and experience after 6 years, is that CARP comes with a significant mandate given the size of your membership. And that's important, but so are all the individuals talking to their individual MLAs as well, important, Anthony. So it's sort of the two-pronged approach, right? So you go as individual citizens, and you also go as CARP representing a number of people. And I think that would be an effective way of approaching it.
Thank you. Perhaps we'll go to Richmond and Fred Harwood, the president of the Richmond Delta chapter. Fred, can I ask you to share your question?
Thank you, Anthony, and thank you, Isobel. Our chapter has been a vocal advocate for vaccinations for seniors. And as the world is now looking for a vaccine for the COVID-19 virus, it's equally important that we look for the best available vaccines for seniors. The high-dose flu vaccine is 24% more effective than the standard flu vaccination. But BC has not made it available to our seniors. And even last year, we had a problem when Ontario, with 500,000 vaccinations, we were delayed and we didn't get ours until December because we were a much smaller number of 5,000 to 10,000 shots. So we're looking for what can be done to make a more universal approach to vaccinations for BC seniors? How do we go about getting this, especially at this time, to make it more applicable and more effective for leveraging with our government to get it into the BC Medicare program, that these senior vaccinations will be supported financially?
So the first thing is, Fred, my understanding, and this is subject to confirmation, and I apologize, I meant to confirm this before this meeting, is that BC will be providing the high-dose flu vaccine in all of our long-term care homes this fall. I believe that is the case. The rationale for it not being the universally free vaccine has been in working with public health. They have a whole calculation on efficacy, numbers to treat, et cetera, and they look at various things. And they have not supported that it is sufficiently more protective for the target population. That's an opinion of a body of the epidemiological public health experts. I certainly think that at a minimum, they should allow seniors to access the high-dose vaccine, and that it would be funded through Fair Pharmacare, which means that it wouldn't be free to you if your income was of a certain right. So if you are not at your family maximum for Fair Pharmacare, you are going to pay for it. But what it would ensure was that nobody was denied the high-dose vaccine because they couldn't afford it. And I am still pushing for that as a minimum. Ideally, it would be funded for everybody. I do know that, and this was part of their debate around where the money would go, is that the new shingles vaccine has proven to be highly effective. And there is, I would say, there was a stronger appetite to funding that as a vaccine based on its efficacy, et cetera, than there was on the high-dose vaccine. My understanding is that people in long-term care will get it this year as the standard vaccine. And I will continue the discussions with government about either it is the free vaccine for everyone, or it comes under Fair Pharmacare. So that's where we're at with the high dose, because I think that as we approach influenza season, I think everybody is going to be very conscious of, we want to ensure that we keep our influenza as depressed as we can, because that puts a pressure on our hospital system, right? And so what we're trying to do is make sure that our hospital system has the capacity to respond to COVID if necessary. And we can create that capacity by diverting traditional visits to emergency and hospital due to influenza by saying, okay, we're going to try the more effective vaccine this year. So it may be, Fred, that they do that. I don't know.
Thank you, Isobel. And maybe stop your screen share, then all our faces will be
there. Oh, okay. Sorry. I'm learning this. Thank you, Fred. There we go. Okay. So I'm so sorry about that, folks.
Well, thank you very much, Isabella. That's good news that if it is indeed the case that long-term care will be getting the high-dose flu vaccine. Glad to hear that, and we'll continue to press for all seniors in the province to be getting it as part of the healthcare system. Let's go out to the Kootenays now, and we'll talk to Karen Bailey-Ramenko. Karen, are you ready with your question for Isabel? I'm going to unmute you here if you haven't unmuted yourself.
There, is that better?
Thanks, Anthony. Thank you.
And thanks, Isabel. As you know, seniors or services available for seniors are not equally distributed across the province. The needs of seniors in more rural areas are just as pressing as those in the larger centers. How can we ensure that these seniors who are not living in the larger centers have access to the resources they need?
Well, Karen, I have to say that one of the most eye-opening experiences from this position has been for me to get out and about and see what life is like outside the bubble of southern Vancouver Island and the Lower Mainland, and it's different. And my concern is that some of those initiatives are going to be put on the back burner for a year while everything focuses on COVID. There is no doubt that a number of the services that are available and the frequency of those services are better in urban areas than rural areas of the province. Some of the issues cannot be fixed, some can. So what cannot be fixed? We cannot magically make a specialist available in every town practicing full time. I mean, we have to acknowledge where there are things we can't fix. But what we can fix are issues particularly related to the economic burden that is placed on seniors living in rural areas because they don't have those services available. That can be fixed. So whether it is a more robust travel assistance program, as you know, it's amazing what it doesn't pay for. When you're in an urban area, you think, oh, well, you're told there's a travel assistance program. Oh, okay, well, then they're taken care of. They get all their, no. It falls far short. And I think, one of the things I say is, nobody goes to Nelson from Vancouver to see a specialist. And maybe if they did, they'd understand the inadequacy of the financial burden. And so the question is, how many people are not accessing what they need because they can't afford to, right? They can't afford to get to the specialist appointment. And, with COVID, telehealth, virtual care will get more emphasis. It doesn't replace everything. There still needs to be the capacity to connect the people. And I think there is certainly a recognition of the need. And as more folks from, well, I think the other phenomenon, Karen, is that we're seeing a shift from people who lived in these communities when they got older, moved to the city. We're seeing a reverse of that phenomenon to some extent. So as the numbers increase, as the numbers of older people increase in rural areas and the demand rises, I think that people will see more supports and resources there. So, that's one of the positive results of this high housing market in the Lower Mainland, is that people are seeing the ability to sell their house in the Lower Mainland, move to some place in the Kootenay, the interior, the north, and enjoy a better retirement, right? And so that's going to build the numbers and it's going to build the need. I know that's a long-winded answer that I don't think really answered your question.
Well, thanks, Karen, and thanks, Isobel. I do see a way forward with some telehealth and virtual medicine being helpful in that side of the care, and we're seeing it happening now out of necessity, but it wasn't taken that way previously. Now perhaps it will be going forward.
And travel assistance is very, very important.
Yeah.
Especially now when we can't even fly to some of the places or get back.
Right.
Yeah. No, and to me, Karen, that's the easy fix, right? The giving the people the money is the easy fix.
Thank you.
Thank you, Karen. We'll go to Ramona now. Ramona is the president of the CARP White Rock South Surrey chapter, and she's also the BC Western Canadian representative on CARP's National Board of Directors. Thank you, Ramona.
Thank you. CARP is advocating for a vast improvement in home care as a solution to the issues that have surfaced in long-term care. Many seniors actually want to stay in their own home. As well, the Canadian Institute for Health Information has reported that up to 30% of residents living in long-term care could be cared for in their own homes if there were proper community supports available, and it would actually be more cost effective. In September of last year, CARP launched a national campaign called Credit for Caregivers that highlighted the burdens of Canada's millions of unpaid caregivers. And we asked that the caregiver tax be a credit to be a refundable tax credit.
Yep.
Now, I know recently Premier Horgan and Prime Minister Trudeau came to an agreement that came from BC and was accepted by the federal government regarding sick leave. So I'm wondering, Isobel, if you could possibly take that to Premier Horgan and ask him to advocate on behalf of BC for the credit for caregivers. So that is one question, could you? And also, what are your ideas about better options for people staying in their own homes?
So first off the top, Ramona, absolutely. I think every tax credit should be refundable. The non-refundable tax credits are of greatest benefit to the people who have more money. They are of zero benefit to the people who most need the support. And that's not the only non-refundable. We want the healthcare tax credits to be refundable. We want, we're working on a report on that. It's part of a whole income report. So absolutely. In terms of home care and home support, we absolutely need to improve that, because one of the ways we can improve our long-term care system is also to make sure that the people there really need to be there, and the people that could be supported at home are supported at home. And part of it, frankly, keeps circling back to the money. So one of the problems in British Columbia is that we have this I'm going to be dramatic, it's a usurious copayment on our publicly provided home support. So if you have an income of $28,000 a year and you need a daily visit of home support, just one visit a day, we're going to charge you $8,000 a year. And that, just isn't going to work. And so people end up going into long-term care because they can't afford our public home support. So it's a very simple initiative. I've talked about it before. I'm talking about it again under the rubric of a COVID response, which is just give the people them. If we turned to you, Ramona, and said, Ramona, if we gave you $4,000 to take care of your mom, do you think you could do that? Like $4,000 a month? I think Ramona might say, I can do that because I can add maybe another $3,000, and now I've got $7,000 a month for mom. And guess what? I can hire a full-time live-in caregiver for mom. Right? Right now, what's going to happen is your mom, we're going to spend $4,000 caring for your mom in a care home, and you're going to give your mom's going to give her resident contribution. Let's say it's about $2,500, $3,000, and actually it won't work for everybody because it needs a Ramona. It needs a spouse who can put it all together, or an adult child who can put it all together, right? So there's still going to be the senior who lives alone, family is nowhere. No, they'll need to go into long-term care. But for those family members, or for those, residents who have very involved family members, we sure do not encourage them to care at home. I mean, Karen Terrell, you work in this field with families, and the public system, we start out by saying, your mom needs full-time care, and so we'll put her on the waiting list, and we'll, instead of saying, do you want to try and make this work at home? Because here's what we could do. If we started with that approach, I think more people would care for their loved one at home. And maybe we can try something during the pandemic, right? So I'm working on that. But yeah, home care, absolutely. Big piece.
So what I'm hearing is perhaps you're considering using that CISL program, the CISL, where it's providing those family caregivers with the funds to make their own choices. I know many families have been refused that support when it comes to dementia care.
I know, Karen. It drives me insane. It just drives me nuts. And it is based on some, in my opinion, some antiquated ideas about what people should be doing. And you know, what is it? Necessity is the mother of invention. And so maybe now when we are really focused on not having ALC beds and really focused on how we can smooth out our long, maybe now, if we could just divert, if 10% went diverted, even 10%, right? We're looking at free, that's 280 long-term care beds, right? That are available for people on a waiting list or waiting in a hospital bed.
You pointed out earlier the hardship that family caregivers are going through right now because of not being able to access the adult day programs for their much needed respite. So I'm wondering, do you know of any discussions that are taking place as alternative options for these caregivers? Because they are at this very moment burning out.
No, they are. I spoke to a 91-year-old woman whose husband went 3 days a week. He's gone nowhere for 3 months and they're in an apartment. And I mean, this is part of also the challenge I have with the visiting program, right? And part of this balancing act, this is an extremely difficult dilemma, right? Because we cannot, to provide what people want, Karen, is they want somebody else to be with their loved one while they get a break from them, right? There's no dressing that up. I mean, you can talk to somebody on the phone, you can do all of that, but you just want to get away from it. And with the kinds of COVID restrictions we've put in place, like there's no adult day program to send them to, there's no, and we've done it under the, safety protocol. We don't want to expose them to, but there's a balancing act. Same with the visiting policy, right? We are restricting visitors coming up to 3 months in long-term care to keep everybody safe. Well, more people have died, many more people have died of non-COVID related conditions during this whole time in long-term care than COVID. And if not now, then when, right? So if we're saying it's not safe enough now, well, when will it be safe enough? Right?
Are we able to get your support on advocating for these issues, including the ratios for the staff in long-term care to resident ratios, as well as the family caregivers needing some kind of respite, whether it's enhanced in-home support to provide that 4-hour break?
Yeah, absolutely, Karen. I'm on record. I have, as I said, I've done I've admitted, I've done a 180-degree turn on regulating care ratios. I knew, and that's why I know, my former colleagues I know how you think when you're on that side, but I know when you're on this side and you sort of see everything and you see the big picture, you realize, nope, this isn't working. Yeah, it works for some, and some do it the right way, but not everybody.
Last thing I'll just quickly mention is that if you aren't able to make that sudden change in the staff ratio for the entire day, perhaps consider during the sundown hours and the evening shift that are usually minimized, where the difficulties in seeing behavioral changes with the majority of the population in care home. And when those ratios are dropped in the evening, as they have been for years, that's when problems arise. So even if it's just changing the few hours in the day.
Ramona, did you get everything out that you had on your mind for that question?
Yes, I noticed there's a question though that Premier John Horgan announced $50 million in payments to the United Way for the Better at Home Care program. And perhaps Isobel might like to respond. How are those funds actually being used?
Okay, so I did that a little bit in my presentation, Ramona. So basically it covers about 2 years. It's not all 1 year. Initiative number 1 that was done immediately was the expansion of BC 211 to all of BC. It was only available in the Lower Mainland and Vancouver Island. Now it's in the interior and the north as well, that number 1. Number 2 was the Safe Seniors Strong Communities program. That's the one where it's the grocery, where we matched up, if you want to volunteer, call 211. If you need help, call 211. We match people up, groceries got delivered, virtual visits happened, etc. That's been highly successful. There's been about 50,000 virtual visits, 10,000 grocery deliveries, 10,000 meals delivered. None of them found their way to my house, but they all got, so that's part of it. Then ongoing It is to expand the geographic areas covered by Better at Home so that hopefully we will get to the point where all of the province, wherever you live, there's a Better at Home program that covers you. It may not be technically in your community, but wherever it is, your community is part of their geographic area. And also to deal with the waiting lists for housekeeping. I was very, pardon me, very surprised when we first looked at this that there was something like 2,400 people on the waiting list for cleaning. So it's to deal with that. So that's where the money goes to the United Way of the Lower Mainland, but they're sending it out to the 68, I just have to cough just a minute. They're sending it out to the 68 current Better at Home host agencies. And either there's going to be more host agencies or the host agencies will cover a bigger area, right? So that's where the money's going.
Yeah, I had several friends, older friends, who have taken advantage of that service, but some of them needed a gardener just to come and clean up the yard, and the wait list was astronomical. She never got anybody, had to end up hiring someone. So some of it is working, some of it isn't.
And I would say, Ramona, we haven't really seen the impact of that money yet, right? It's the first tranche and emphasis was on this Safe Seniors, Strong Community Groceries COVID thing. Now it's working its way out to the various agencies and communities. So I would say by about the fall, the clients on the ground will feel the difference from that additional infusion of money.
Good. Thank you very much, Isobel.
Thanks, Ramona, and thanks to all the chapter presidents. I'm going to try and get some questions from those who have been waiting patiently with their Q&As in our chat form, and those who have raised their hands. We might take the risk and bring some people on as panelists as well, knowing that they are members of our association. But the first question I want to read to you, Isobel, is from Lorraine Herlick. And she says that she's concerned about seniors having access to a family doctor. Hers retired in 2016, and she's been going to drop-in clinics. Will there be changes to the way doctors are paid to encourage doctors to go into family practice?
Very good question. So the short answer is through the medical services plan payment for physicians, there are some incentives to take on older patients, and there are so the government has worked at incentivizing that. In terms of family practice versus one of the other specialties that might be associated with acute care, that's difficult and tricky. They're trying various ways. There's the issue of GPs getting people to come into family practice, and then also getting family practice physicians to go out to other parts of British Columbia, Karen Bailey, further to your, the issues in rural BC. There's no magical solution. One of the things the government has done is set up these multidisciplinary practices. They've done quite a few of them in the Lower Mainland and here on the island, where you become a patient not of a doctor per se, but of a health clinic or a practice. And so given what you're presenting with, you may see a nurse practitioner, you may see a physio, or you may see the physician. That has some hope, but it's not the panacea for everything. It's going to continue to be a pressure, I think. And it's true of there's shortages in many areas, not just family practice.
And that we understand that the changes that are required really come in the medical schools, where they have very little training in dealing with seniors. And as our Dr. Sinha says in Ontario, it's not that they don't want to treat seniors, they're afraid because they haven't been properly trained in how to care for seniors on the geriatric side. So something that we have to improve in the training as well. I'm going to go to our next question, if I can roll it back up here. Oh, so this is, no, I'm sorry, I just bounced around. But the question was from a woman in Coquitlam, which I've just misplaced. But her question was that her and her mother both live in Coquitlam, and the mother is living in long-term care, and she hasn't seen her since March the 16th, I believe. Now, this is a real face on this issue. We've been talking about access to residents and visiting in long-term care. We're talking about the numbers, but this is an actual CARP member who isn't able to see her own mother. And she calls it cruel and unusual punishment. Is there a responsibility on the government to not be as paternalistic for these residents and allow them the right to see their own family members in as safe a way as possible, but to go above and beyond to grant them the access that they require, perhaps they have the right to?
Yes, this is a very challenging issue. I think we do need to allow a lifting of some of the visitor restrictions. I think we can all appreciate it can't go back to, you can come and visit whenever you want, and it can be the grandkids, and it can be. I am very concerned about the spouses who can't visit and the adult children who would visit on a regular basis, sometimes daily, and what the absence of that person in the life of the resident means. And when you're seeing the nice pictures on TV of the, senior waving to their family member, and I mean, Karen Terrell, and she and I know that's not the typical person in long-term care. The typical person, and the one I'm worried about, is the one who's going to have difficulty even talking on the phone to their loved one and the ability to communicate. The other concern I have is that it's not no visits, it's restricted visits, and there's a definition of essential visits, but there is a lack of clarity around where a person goes if they think they're an essential visitor, but the care home has said, no, you're not. Different care homes are applying it very differently, and that's clear from the calls I'm getting into my office. And it's done with the best of intentions, but the writer is correct. We cannot bubble wrap our seniors. One of the points I mean, you can appreciate, and there's 307 people out there who are going to hear me opine on this. So it's always dangerous that somebody's going to say, oh, they say it's okay to die in long-term care. That's not the case, but we need to understand that in any given month in this province, about 650 people are passing away in our care homes. And so what are we protecting people from? And in the totality of our lives, all our lives are going to end at some point. And in the totality of our lives, what has meaning? It is different for different people, but though ability to have the conversations that you can't have over the telephone or an iPad with Zoom in what might be a person's last 2 weeks, month of life, the fact is you don't know it's necessarily the last 2 weeks or months of life. One of the things I've said, and those who are on the call who work in the field will understand our medical orders for scope of treatment, I've said, anybody who's indicated they're at a do not treat level on their most is palliative. The minute they get an infection, we're not treating it. Sepsis is going to take over, and they've basically signaled that they're palliative. But we aren't allowing visitors until the last 48 hours of life, and you can't be precise about that, frankly. We don't know exactly the last 48 hours of life. We know when you slip into a coma. We know when you are going to be sedated to the point where there can't be engagement. So we really need, because the weeks are stretching into months, and we are expecting a resurgence of COVID in the fall. So a reasonable person would say we will probably need to see restrictions imposed in the fall. Last year, we had 187 outbreaks in our care homes. Whenever there's an outbreak, units within a care home or an entire care home are on lockdown, not for this, for the 2 weeks or 10 days that the virus, the influenza usually, or the norovirus is circulating. So what are we saying? That there will be no visits for a year and a half? The median length of stay, interior actually has the shortest. It's was looking this up. It's like 350 some days. So 50% of people, they aren't even in there for 350 days. So we really, it is a very difficult decision because there is a risk. There is absolutely a risk from visitors. We can't, I think we can mitigate that risk significantly with proper infection control protocols. Absolutely. Can we mitigate
testing,
it?
And testing for sure.
And testing, but they're all limited. There's nobody can guarantee you. So what people fear is, allow visitors and suddenly COVID is introduced, and we can certainly see how it gallops away, can gallop away from you, although not always in a care home. But I think we need to find a way. I think we were supportive when it was going to be a few weeks, going to be a month. Okay, 2 months. Okay, now it's 3 months. But we've got to think this through. What are we saying? Never?
Yeah, I think that message has to get to the decision makers quickly. And I know it's relatively a small group of people who are affected by it, but it is just heartrending. And it really has been too long. I think we need the public health authorities and the provincial government to act on that as soon as possible.
Yeah. And so my advice would be let your thoughts be known.
Okay.
Contact the public health,
Yes.
contact your MLAs, let your thoughts be known.
Right. Thank you for that question. I'm going to try and allow someone to join by talking. And Sharon Bennett, you have raised your hand in our Q&A section. So I'm going to allow Sharon to talk, and I'm hoping that she's there when I press this button now. Sharon Bennett, are you there and able to ask us your question? I will unmute you if I can. Okay, Sharon, I'll go down to the next one, which is Barry Yee. Barry, I'm going to allow you to talk now and see if you're able to join us.
Yeah, good morning. You copy me?
Yes, Barry, we hear you. Thank you. Go ahead for Isobel.
Well, okay. I live in South BC, where we're sort of like a retirement community. We got a small hospital, and the thing I'm asking about is what plans are for possible, more than yourself, being a logistics expert in scheduling all these care homes. Rather than taking the job on, sound like you're taking the job on by yourself. That's my question.
Thanks, Barry. Did you get that, Isabella? I think it's you are taking this on perhaps all by yourself in dealing with the care homes. What other resources are at your disposal and the province's disposal to make these things become reality?
Well, certainly the health authorities have a team actually that deal with all of the care homes, and certainly a lot of the current direction is coming through medical health officers. So, there's the provincial medical health officer, and then each health authority has a medical health officer and team of people in that health authority that work with the provincial office. So I think there is quite a robust group of very committed people to ensuring that our improvements are made in our care home, and they certainly have identified the need for those for that care and for improvements. I think there is a challenge around the visit policy for all of the reasons I already talked about.
Thank you. I'm going to call on Angie Morris. Angie, if you're there, I'm going to open your mic now and ask that you ask your question of Isobel. Angie Morris, are you there?
Can you hear me?
Yes, we can hear you. Go ahead, Angie.
I was wondering, Isobel, if there's going to be any improvements in the working conditions of people who are helping seniors both at home and in long-term care facilities. By and large, I think they're not particularly well paid or well recognized.
So the short answer, Angie, is yes, certainly as it relates to care homes. One of the things that the provincial health officer did do through a provincial health order, so that's important, it's got teeth, is that all of the care aides are going to be paid at the highest level, what we call the industry standard. That is not insignificant. And they haven't actually got the money yet, but it's all retroactive to a date back in April sometime, and it will be ongoing. And I think that when the pandemic is over, I don't think you can put that genie back in the bottle. I think that that is going to be a way of ensuring that people are appropriately paid. And I think that that will have an impact on the recruitment issues, because you certainly saw there was a relationship between, you know, I can't get anybody and what am I paying? In home care, I think that for many home care workers, certainly those who are delivering the provincial home care program, there is some recognition in terms of wages of the level of work they're doing, but we need to do a better job of giving them full-time work or close to full-time work. In sort of the private world out there of people who hire their own care staff, I think that there will remain some challenges, and this balancing between what seniors want and can afford, and what kind of help that they need. But I hope that the pandemic unleashed, in my opinion, a wellspring of care for seniors that I don't think some of us thought was quite there. And that was heartening. You know, you heard that, you hear other comments and ageist comments, and you sort of wonder how prolific, you know, do people, what are people's real opinions of seniors? But I think the political leaders, I think, have had a wake-up call, and that's important. And I think that we'll see changes. They're not going to happen overnight. It's going to take 2 or 3 years probably before we see the full effect, but I think we will definitely move things forward.
Well, thank you very much, Isobel. I think that as I look at the time, we're close to wrapping up. So I'll thank you formally now and bring it to an end, and bring to the end what has been our first virtual CARP BC meeting. And on behalf of our chapters, all of our members who joined us today, and all the CARP members in the province, thank you, Isobel, for your time and for acting as our advocate to the government. We wish you success and continued success, and encourage you to continue the good fight. CARP members are here to support you and help you to persuade the government to take action with the power that we hold at the ballot box. And speaking of the power of CARP, I do want to encourage each of you to renew your CARP membership and help us through the economic pressure of this pandemic, and please sign up a friend if you can afford it. Encourage a family member to join. With 320,000 members across Canada, if every one of you could get another to join, we'd be close to 1 million. And just think how quickly we could make the changes that we're all advocating for. Please keep an eye out for more of these virtual chapter meetings being scheduled for the summer. And until we can meet again safely in person, I know plans are in the works with a number of chapters, and you should be hearing from us again very soon. Thanks again to everyone. Thank you to our chapter presidents and to Isobel, and for everyone who joined on this call. It has been recorded. We will share it with you on our carp.ca website, and I hope to see you all again very soon. Stay safe. Thank you, everyone. We'll bring this meeting to an end. Goodbye.
Thank you.
Thank you.